Good morning or afternoon, everyone, and welcome to the webinar today. I want to thank Denise Osbeck and Beth Stroll for inviting us to your monthly System of Care Expansion Leadership Call. And I know that there will be a number of new grantee webinars that SAMHSA will be using to provide an overview of the grantee requirements, and this particular webinar on behavioral health disparity impact statements is one of those. So thank you all for joining us to talk about the Behavioral Health Disparity Impact Statement. My name is Kathy Lazier with the University of South Florida, or USF. USF is a core partner of the TA network. I'm presenting today with Dr. Peter Gamache from Turnaround Achievement Network and the University of South Florida. Peter has led the TA network's technical assistance efforts for the Behavioral Health Disparity Impact Statement since it was first required of grantees by SAMHSA. So we'd like to begin with a brief introduction. Let me advance this slide. We'd like to begin with a brief introduction and then discuss the need and rationales for a behavioral health disparities impact statement, followed by some concrete examples of how to create a disparities impact statement, and then lastly, how to gather and interpret disparities data. And we'll have time at the end for some questions. And I know Peter has some polling that he'll be doing during his presentation as well. So you are all probably on this call because you know that the Behavioral Health Impact Statement is a requirement of SAMHSA. The system-wide policy and requirement for grantees of SAMHSA is to establish and develop behavioral health disparities impact statements. It's an important step to advance the quality of behavioral health care for children, youth, and families. And the primary purpose of an impact statement is to assess and heighten the impact of policies, programs, the processes, and resource decisions that you make to achieve health equity by reducing and eliminating behavioral health disparities and disproportionalities. So from fall 2013 and onward, SAMHSA grantees and programs are to achieve the following. One is to outline their population or populations of focus by race, ethnicity, and sexual orientation, gender identity, or LGBTQIQS status. They were to address identified issues regarding data collection, service implementation, and data reporting, and also to plan their policies and procedures in a way that aligns with the National Cultural and Linguistically Appropriate Services Standards, known as the class standards that many of you probably have heard about. For many grantees, this is the first time that they have ever been asked to collect and use some of this data, while others are more advanced. Some have centers of excellence or are partnering with universities in various areas of the country. Documenting these core needs, the challenges, these opportunities, and lessons learned that can be shared across grantees will provide a national view of program successes, and it can also be a foundation from which local achievements can be measured. So I mentioned a moment ago the National Culturally and Linguistically Appropriate Services Standards in Health and Healthcare. And the purpose of the class standards is to advance health equity, to improve quality, and to help eliminate healthcare disparities by establishing this blueprint for healthcare organizations. Its principal standard is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, to preferred languages, health literacy, and other communication needs. The other 14 standards focus on governance, leadership, and workforce, communication, and language and engagement, and then continuous quality improvement and accountability. And Peter will be addressing these in his presentations and giving you some very concrete examples of what this might look like in your implementation plans or your strategic plans. You can read more about the blueprint at the Health and Human Services website, Think Cultural Health. The other thing that I wanted to leave you with in terms of the class standards is that the beauty of the class standards is how easily they align with the principles of system of care. So using class as a foundation, you can assess how you are doing in your frontline practice with functions such as assessment, service planning, care management, coordination, services, supports provision, workforce development, You can see how it aligns in the community in terms of, for example, with partnerships with families and youth, using natural helpers and the community buy-in. It aligns in terms within management around elements such as data, quality improvement, human resource development, and system organization, and also with policy regarding system components like financing, regulation, and rates. So that you can see how integrated class standards are in all of these, and you'll be able to see how the behavioral health disparity impact statements can really help you to see whether or not you're achieving some of the other thing I want to talk about just lastly, just very quickly, before I turn it over to Peter, is I want to mention an important concept in addressing disparities in access and utilization. And it crosses into intervention strategies, and that is considering social determinants of health. So social determinants of health are the conditions in which people are born, grow, live, work, and age that could contribute to or that detract from the health of individuals and communities. So social determinants of health account for a very large share of the barriers and challenges to optimal care, mental health care. So what happens is our support systems often fail by operating in these silos and primarily focusing on individual risk factors. Looking at these social factors and the availability of resources to meet daily needs like access to safe housing and transportation, the availability of nutritious food, jobs, and health care, also access to educational and community-based services, it can get you outside of that silo. So, you'll be hearing a lot about, and you probably have already, in terms of the foundation or the focus on social determinants of health. Using a public health framework is similar, and wraparound, an approach that most of you use, is based on gaining an understanding of all the domains of a child and family when doing service planning and care coordination. So it's this framework that really helps us get at the root cause of health disparity or health inequity. So I'm going to go ahead now and turn it over to Peter, but we wanted just to set the stage in terms of how the behavioral health disparity impact statements really are a part of this bigger picture of using class standards as a foundation and also the concept of the social determinants of health. So Peter, turning it over to you.
Thank you, Kathy. Thank you to you and to the TA Network for this webinar to address this topic and to help grantees to meet the requirements and really make meaningful changes within their communities. I want to say that I'm definitely proud to be in the state of Mississippi today with 5 systems of care that are operating successfully within the state of Mississippi. And a special thank you to our host, Dr. Sandy Rogers from Communicare, which is the new grantee community who's hosting the connection today. So thank you to all of you and for everyone on the call to join us, and to all the incredible great work that you're doing in your communities to really make a difference in people's lives. So I wanted to talk a bit about the need, about why this is important, what are the needs and the rationales for why looking at behavioral health disparities data and taking into account policies and procedures that are data-informed and data-driven, and how they can really translate into meaningful practices for communities and for families and youth. And so when we talk about disparities and disproportionalities, sometimes I hear a lot that there's a sort of catch-all term where people will sometimes default to saying, well, that's a disparity and this is a disparity, and disparities topic that you'll hear in different meetings. And sometimes the language is, the way that they're discussing the need in a community is not necessarily a disparity, it's a disproportionality. So there's a distinctive difference in terms of using precise language around some of those needs. And these are tools, meaningful tools for being able to show and illustrate need within a community. So a disparity is an inequality marked by a comparative difference. Right? So that's a core operational definition of what characterizes what a disparity is. And so, for example, if we were to say, well, there are differences in access to quality care for males versus females, right? If we were to look at side by side how males versus females do in terms of their access to quality care, then if there's a difference there and where someone's getting lesser care or lesser quality care, that's a disparity. Right? It's a great example of a disparity when you're comparing a group side by side with another group. And a disproportionality is skewed representation of a given population group, right? And so this is a overrepresentation or underrepresentation of a certain group. And so if we were to use an example, it would be that African American men represent a majority of new HIV infections despite comprising a minority of the overall population. So as a minority group, they are comprising a certain percentage of the overall population, and then as people who are African American men who are affected by new HIV infection, there is a much higher percentage among that group. So when we see a big percentage increase like that, when you're comparing within the group, that's a disproportionality. And we're going to go through some examples of what we mean by this to kind of get to the next point on clarity for it. So let me just do a quick poll for what everyone thinks in terms of whether this sounds like a disparity to you or is it a disproportionality. Racial and ethnic minorities endure higher rates of morbidity and mortality than non-minorities. And morbidity are things like chronic diseases and other things that are adverse health effects. And then mortality is where people will die earlier than they need to. So if you were to compare racial and ethnic minorities enduring higher rates of morbidity and mortalities in comparison to non-minorities, what do you think? Is this a disparity or is it a disproportionality? And I'll just give everyone a second to vote. I see the totals are still calculating. And thank you for voting. All right, so we're seeing some percentages that are nearly evenly split. We're seeing that there's a lot of disparity and disproportionality votes, pretty much almost even. And so the answer to this is that this is specifically is a disparity because it's an inequality marked by a comparative difference. So we're basically lining up looking at the rates of morbidity and mortality among non-minorities on one side and minorities on the other. And so when we do things like that, when we're comparing a group to another group, that's a disparity. So let's run through another one. What do you think of this one? Racial and ethnic minorities experience greater challenges accessing behavioral health services compared to non-minorities. What does this sound like to you? We'll just let the numbers total up a little bit on the poll. Right, so the majority are seeing that this is a disparity. And that's correct. This is another inequality marked by a comparative difference. So let's do another one and see what you think of the next one. The local detention center confines a higher number of African American and Latino youth compared to the racial and ethnic makeup of the county. So a local detention center and the number of African American and Latino youth in that detention center compared to their representation in the larger surrounding county that they live in. That's a disproportionality. Right, and so that's correct. So basically the way that I think about this is trying to visualize like a pie chart sort of way of looking at it, where let's say minorities represent 15%, the small slice of the overall population of the pie chart on the left side, and that's their representation in the overall county or state or region that you live in. And then let's say you're looking at a social issue like juvenile justice incarceration or substance abuse or other challenges or other school dropout. It could be lots of different social types of indicators. And let's say that among that population they're doing that they are finding that they're overrepresented, meaning let's say it's like 50% school dropout within the African American and Latino youth community, right? So that would represent a disproportionality because we're comparing their proportionate effect of the social issue on them, on that population. So it's a beneficial concept to use when you're speaking about the rates of different social-related challenges that different communities have. So why is this important? So getting back to the point of this is an important topic, it's really needed. Well, it's definitely increasingly required by federal funding agencies, so it is hooked to the money. And so that is definitely another major administrative reason to pursue behavioral health disparities and to generate and follow the behavioral health disparities impact statement. And so SAMHSA has really been an incredible leader in this area. The Substance Abuse and Mental Health Services Agency Administration has a portfolio of different grants and programs. There are the System of Care programs, of course, that you all know about. There's also Targeted Capacity Expansion, or TCE HIV programs. Many times they will release them for specific populations like minority women or minority populations. There's the Offender Reentry Program, or ORP, and there's also another area within their portfolio called the Grants for the Benefit of Homeless Individuals, Services and Supportive Housing. So among SAMHSA's entire portfolio, the point of looking at it like this is that it's not just systems of care that are required to look at disparities and to follow up on them and to have plans for addressing them. It's across SAMHSA's entire portfolio. So there are lots of different synergies that can be gained in terms of connecting with grantees who are among this portfolio and sharing data and best practices and resources, because they're all having to have a behavioral health disparities impact statement as well and follow it. And so there's a compliance-related rationale, a funding-related rationale. It's in the Notice of Grant Award as a term and a condition of a requirement for accepting the federal funding. So there's a financial aspect to it, there's a compliance aspect to it, and then it's the right thing to do, right? It's the way the quality services are operating. So we're going to get to some additional rationales in that area as well. Many good reasons that are behind this. So what we have found is that traditionally what this is doing is it's shifting the perspective when you're looking at social determinants of health and you're using a behavioral health disparities impact statement as a tool for examining these broader social related challenges that people have. Because traditionally what we have found in many of our research studies, and Kathy Lazier and I have co-published several studies on this and monographs, it is that we have found is that in many communities there is a person-based perspective in terms of it's the person that's risky, right? It's the individual that's at risk or seen as at risk. And sometimes when we're in the professional services world and we hear terms, it's an interesting way that people are being sort of categorized as, for example, at risk. That's an at-risk youth, right, or a high-risk youth. And we've even seen risk-prone, right? And these are labels that are not necessarily very constructive or empowering for people, to be told that you're risk-prone, right, as an individual is not a good thing, or you can emphasize that someone is at risk because of their behaviors or their individual, circumstances, but there's a broader reason in terms of a social determinants of health of what is surrounding their lives, of why it makes it so that they're risky. So it's not just the person sort of walking around, on the planet who is risky themselves. They're also in risky environments that they find themselves within. So behavioral health disparities, basically, the impact statement helps to gain that bigger picture. So it helps to go more macro in terms of looking at the larger perspective around risks and their needs. And so there are other major reasons for why this is important to look at broader macro-related trends. It's important to examine behavioral health disparities because we have, quite simply, an increasingly diverse population. I mean, that's the primary rationale for why we need to have services that are tuned and adaptable to different populations' needs in terms of emerging populations, in terms of migration-related patterns and trends. There's a lot of different changes that are happening demographically across the United States in terms of race and ethnicity and in terms of their visibility. So the LGBTQI2S community, which if everyone's not familiar with the full acronym, they may have seen LGBT, which is a common way of describing lesbian, gay, bisexual, and transgender people. But SAMHSA has a more expansive, inclusive acronym or set of ways that they look at this population as a group, as a whole. It's LGBTQI2S. So there's the LGBT, lesbian, gay, bisexual, transgender. Q is for questioning. The I is for intersex. And 2 is for two-spirit. And two-spirit people, it's reflective of the Native American community's perspectives on spirituality and people having gendered spirits within them. So it's an incredible cultural way to look at the LGBTQI2S community. And they've become much more visible in society and in the media, and now with the Supreme Court decision last year. And so there's a lot more visibility of this population. And by race and ethnicity, we're seeing multicultural and multiracial people. This is expanding more so every day in the United States. And the way that we know this is that from the U.S. Census, there's an evolution of population groups that are mixing and merging across the United States. The question on multiracial U.S. Census question that was released started in the year 2000. So for so many hundreds of years in our country, we had limited categories on the United States Census. And actually, it's just a fun trivia fact, is that the first U.S. Census really only had 2 categories for racial categories, and it was white and black. And that was the only 2 that were on the United States Census. So now we have many more categories, much more inclusion, and ways of having people be able to respond more accurately and more closely to their self-identified categories. And then the question on the U.S. Census that was added in 2000 was about same-sex households. So people who are living in a same-sex household where it's a shared resources in terms of same-sex marriage, as well as people who are heads of households that are living together. So we had civil unions several years ago, and then now it's moved on to same-sex marriage nationally. So now the data are coming to show that trend and that increase behind it. So if we look, and I know I'm not going to go through all these little numbers, and a lot of them are very small and hard to read, but just I want to take a sort of broad brush on looking across the United States at the 2 or more race population. So among people who are self-identified on the 2 or more race question in the 2000 census compared to the 2010 census, it has dramatically increased just within that decade. So to the year 2016 onward, we know that there's an increasing trend upward of people who are increasingly self-identifying as having 2 or more races. And you can see on the map to the right, there's a density map where there are larger densities or numbers of people who are living in certain states across the United States who are more so identifying than other states with more 2 or more race populations. But even in the lighter shaded, lower density areas, there are still migration patterns. There's changes of people, increasing over time. So if we looked at those columns to the left, and I'm just going to spot, a few of these. If we looked at the Northeast and the West and the South, that's been, as a sort of cluster. There have been expansive changes from the year 2000 to the year 2010. And then if you look at every single individual little state that's listed there, even in states where you might not expect, in some rural areas and places that are less densely populated, every single state that's on that list has a marked increase, even almost a doubling of the numbers of people who are, identifying as 2 or more races. So the country, the self-identity of the country is definitely changing in that aspect. And so what's behind this trend? Like, what's the reason for this? Well, there's definitely changes in social norms and policies that have been, able to be shifted and addressed and to meet social equality needs. So we see the intermarriage trend, for example, just from 1980 to 2010, which is a 30-year span. This is the little graph on the left here of all marriages versus new marriages, the big trend line above the all marriages category. if you just track across time from 1980 to 2010, which really isn't that long ago, it's in most of our lifespans, is that we see a marked increase of intermarriage between the percentage of marriages involving persons of different races or ethnicities from one another. So in 1980, for example, we were at approximately 6.7% of all new marriages were for people who were marrying someone of a different race or ethnicity. And then in 2010, that number leaps to more than double at 15.1%. So there's a lot of intermarriage now that's happening. So that's one data trend that we're seeing. And then the attitudinal trend is also changing dramatically. Social norms are definitely changing in terms of perspectives around different racial and ethnic groups, LGBTQI2S populations, and others. And so we see, for example, an example of this from the Pew Research Center, where they looked at 1985 to 2010, so that's the bookending of the ranges that we're looking at, and the acceptance of blacks and whites dating each other from this, actually it's 1987, so it starts a little 2 ticks up from 1985 on the little x-axis there on the lower left-hand corner. So it starts at 48%, and then it jumps to 2010 to 83%. Again, an enormous sea change in terms of acceptance of blacks and whites dating each other, and this is a national representative sample. So huge social norms and beliefs and perspectives that are changing. And then if we dig a little further and we ask, well, okay, what does this mean in terms of where this is being driven by? Excuse me. It's being driven by the youth. Youth now are the ones with the socially accepting attitudes more so than the older generations. And you can even look at this decade by decade. So the 18 to 29 group, if you look at the youth that are, where they say that there are all racial and ethnic backgrounds are more supportive of interracial marriage. So it's the percentage that are saying that they would be fine if a family member were married to someone of a different race or ethnicity. The youth, the 18 to 29 group, have very high rates of acceptance to this statement. But if you kind of start looking down to the 30-year-old to 50-year-old to 50 to 64 and then 65, ages 65 plus, they are much less accepting than the youth. So this is definitely being driven by major social changes that we're seeing. And an example of a policy change that's also helped to keep these things continuing is the Supreme Court's Loving versus Virginia decision in 1967, where they declared that it was unconstitutional to have anti-miscegenation laws, so where it was flat out illegal to marry someone of a different race, right? So that got struck down, and then now we saw last year with the 2015 Supreme Court decision on same-sex marriages, kind of like history was repeating itself a bit of social equality happening. So we're starting to see that the changes are definitely happening in terms of the face of the nation and how people are more visible than ever before. And this applies definitely to the Hispanic population. This is a great visual from the Georgetown Public Policy Review. And it shows certainly denser areas of where the Hispanic population is more so concentrated than in other areas of the country. But if you were to zoom in on specific states, you would see clusters of color showing up, right? And so this helps to sort of provide a snapshot of where a trend is moving, but it's definitely spreading across the United States. So diversity is definitely alive and well, and that's part of our strength in the United States. And we also have data on same-sex couples raising children. This was on the 2010 U.S. Census data. And sometimes I hear in certain communities, we don't have those clients. They don't live around here. We don't serve people like that, or there's a sort of instant belief that there are no LGBT-related, same-sex parents or children being raised by same-sex parents, et cetera. But we have data now that is showing objectively that it is certainly across the entire United States. Every single state has this population. And even in some areas where you might not expect large percentages, you will see this as well. So, for example, the Jackson Free Press just a few years ago. That's 2012 date I'm seeing there. So it's been a couple years, or a few years, but they had a news article that said that Mississippi leads the nation in the percentage of same-sex parents, right? And so that was like one of those interesting stories where you wouldn't know that if it weren't for the data. So we see the very interesting things. And then when we look, we can also zoom into specific state-level maps and looking at where are people more so clustered within a state. And this is to full credit to the Williams Institute in California, who crunches all of the U.S. Census data on same-sex households and same-sex couples raising children. So these are their maps, and they're just wonderful resources. So I definitely encourage you to visit their website. And if you're ever looking for data, where do we find data around this population, or how do we include them into a grant application, or how do we show an administrator that we have those people who live around here, certainly that's a public resource to you to follow. So behavioral health disparities, when you're taking the bigger picture, what you find is that there are many gaps within and across systems, right? And there are many areas where we talk about fragmented service systems, or maybe some disconnects and delays in people receiving care when they move from one service system to another, or if they're served by multiple systems, of how to navigate all of these different ways to get help. And so we see that there are major gaps within and across service systems for addressing, monitoring, and evaluating unequal access, use, and outcomes. All right, so if we want to look at disparities, these systems are collecting great data, right? Somewhere there's a data channel where they are required to report up to a funder, or an agency report, local program-related report. There are many different sources of data, and I'm going to get into some examples, but there are definitely things to sort of make the puzzle pieces come together to look at how they're interconnected. So we see that there's a child system, for example, just to orient to the diagram we're looking at. If we looked at a lifespan perspective from birth to death, and that's the lower underlying line at the very bottom here, so we move from left at birth, the lower left-hand corner, to death to the right. If we were to follow a person through these systems, there's a child system, right, in terms of special education and child welfare, juvenile justice, child mental health. These are all serving the children, child age group. And then in the middle, there's this transition age, right, when we talk about transition age youth. And that number, 14 to 21, is not a fixed point. It's been flexing, because there are advocates that are, for example, saying that age 21 needs to be much more extended to age 26, for example, because of developmental needs. And so that's a transition age youth range that's in between there. And so people will age out of, for example, foster care or some of these systems, and then if they're not prepared, or these systems are not connected in a good way to best meet their needs, they, unfortunately, what we find in many different research studies that I've conducted and that I've been part of, is that they, unfortunately, you'll find them picked up in the adult system: criminal justice, adult mental health, housing-related challenges, voc rehab challenges, substance abuse challenges, right? So we want to go upstream and try to make it so that there's better communication and better connectedness among the systems of care. So this is basically reflective of system of care values and principles to better get people to work together in terms of having family-driven and youth-guided services. That is a core #1 system of care value and principle. It's also that the services are community-based, they're culturally and linguistically competent, and they're data-informed, right? So if we were to boil it down into some core values and principles, those are those 4 that are listed here. And there's also some major selling points in terms of looking at gaps and looking at disparities and disproportionalities. By doing so, you will increase overall quality and efficacy of care, the quality of life or the health and well-being outcomes for people. You're going to improve communication and trust between clients and providers. There's an enhancement to provider knowledge and skills. And then it improves client and provider satisfaction, right? So these are the wins, right, for looking at disparities and disproportionalities. And there are additional wins in terms of declines. Right? If we looked at the inverse effect, there are reductions in medical and mental health disparities. There are reductions in provider biases and discrimination when they interact and work with more diverse populations. There are delays in seeking needed care and services that are reduced. Right? So when someone is delaying care and treatment, their problems don't typically go away. Right? They get worse over time, much more intensive, much more expensive. So we want to definitely reduce delays in seeking needed care and services, and as I mentioned, the costs definitely go up over time. So in public health, we try to definitely always have a preventative approach, and one of the major phrases I keep repeating is that it's either pennies now or dollars later. Right? If you can go upstream and do prevention, you're going to save yourself a lot of wasted time, energy, and money down the line. So that is definitely the aspect of looking at this. So when we look at the sort of how to do this, we want to have a behavioral health disparities impact statement to assess and heighten the impact, as Kathy mentioned earlier, of the policies, the programs, processes, and resource decisions to reduce and eliminate behavioral health disparities. That's basically the core of its purpose. Behavioral health data, what we find is that there are data that are out there, or they're available, but they're isolated. They're in a silo somewhere. They're trapped inside an EHR that people are not able to, to generate output from, or don't know, the way to tap that data or to analyze the data. In terms of surveys and other things that are like satisfaction surveys, there are training data. There's lots of different ways to gather different points of data within an agency, but they aren't being combined or fully utilized. And so the data are ideally gathered on identified disparities and disproportionalities to address differences in access, service use, and outcomes. So what's the point of looking across, how people are doing by race, ethnicity, gender, LGBT? Well, to start asking the questions, who are the subpopulations that are enrolled in programs? So this is something that SAMHSA wants to know in terms of disaggregating the data. It's not just a roll-up together of one big number of people served. They want actual breakout analyses of how people are being served by race, ethnicity, gender, and LGBT. So it answers the question, who are the subpopulations that are enrolled in programs? And then the use of the services, what subpopulations are getting what kinds of different services? So this is a great illustrative, descriptive reporting and things that you can carry up to community groups, and you can process this and share this within your local communities. And it also helps SAMHSA to carry the message onward to Congress and onward to their internal administrative mechanisms, because they're asking more detailed questions about the people who are being served by their grant programs. And then the third question is, given the specified outcomes of the program, right, what was required in the notice of the funding opportunity announcement, the specified outcomes of the program that SAMHSA wanted to see in terms of what you would deliver if awarded the funding. And then it's also the outcomes that were written into the grant program, and these are specifically things that are part of the template of how the program would operate over time. So given those specified outcomes, how do those vary by subpopulations? So if your outcome, for example, is to improve mental health status or improve a certain health-related outcome, they also want to look at that according to race, ethnicity, gender, and LGBT. So those are the different ways of looking at different population groups, and then you learn an incredible amount of information from looking across those groups that way. What this will do then is that it will help to directly inform the continuous quality improvement strategies that you would come up with. So if a certain population isn't doing very well, right, in terms of their engagement with services or their enrollment in services or their outcomes, then it helps to drive what does our program now need to do to make it so that people are more, that it's more equitable for people to have these services. So after data are collected from various data sources, the disparities and disproportionalities are identified, as I just mentioned, and interpreted to develop those strategies that enhance behavioral health outcomes for clients receiving services. So the interpreted data identifies the cultural enrichment needs of the community, the gaps in services that they experience, whether services provided are client-centered, and again, that goes back to that SAMHSA system of care value and principle of having them as youth-guided and family-driven. So it ensures whether they are in fact client-centered in that way. And then it also identifies whether services provided are culturally and linguistically competent. So what do we mean by this? We mean aligned with those class standards that Kathy mentioned earlier. So how do you put it together? Like, what do we do? You know, that's definitely a common question. How do we get started, and how do we, put this thing together? Well, this is an example of one that was created in terms of stratifying out and categorizing a way to approach all of this information, right? So there can be a part one, a background statement section, and this is where you would want to have what is the big picture, on what's going on in our community. The statistics on overall disparities and disproportionalities. What's going on in our community, our county, our city, our parish, our state? What's the big picture on what's happening out in our communities? And so there's going to be statistics on your program service area. You can look at it again by county or city, et cetera, or by zip code. You're going to look at them according to race, ethnicity, and LGBT, right, where available. So if there's a school dropout rate, for example, can they generate or provide a report that breaks out the population groups that are dropping out of school, for example, by race or by ethnicity or by LGBT? Ideally, you'd want the request is to have all of it, but in some communities you have to sort of work with them and help them and make a request one at a time, where you ask for, can we please have the race, by race information, because you don't want to overwhelm, a community partner when they're doing you a favor or they're generating a report. And so it's not just a one-way channel to you. You're also going to be helping them to put an offer on the table to get back with them on, your data and how your systems connect with each other. So that gathers the way to look at your broader community. And then there's the impact statement itself. So once you've seen that there are areas of need in your community regarding specific subpopulations, right, then you're going to have an impact statement for how your program is going to collect it. Because a lot of times systems of care, they're operating in communities that, the school system doesn't collect LGBT data, or the local prison system or juvenile justice system is just not able to generate specific report in a certain way. So then the idea is to fill the gaps, right, at least in the program. Among the people who are enrolled in your program, you can address that data gap or that data need by looking at that disparity. And then it's a way of looking and developing plans for developing policies and procedures that will address those disparities. So once you've highlighted it with the data, you've shined a big spotlight on the issue, right? And then your program is going to also be collecting data on that in terms of an ongoing monitor of what's going on with it. Then you're going to develop plans, right, for how the program is going to address the issue. So I think this is conceptual stuff, so I want to definitely provide a specific example. So we worked with a system of care, and we looked at the juvenile justice statistics, and we found that there was an incredible amount of engagement that was very disproportionate among the African American male youth that were enrolled in the program. So that was a huge disparity that jumped out at us in terms of a major data point or a major source of information that was informing, hey, this is a real major need in the community. So then the system of care started generating things like fact sheets on the issue, right? Generating a nice one-page handout that could be used at community meetings. Like, this has been, an issue, a little pie chart, something very accessible, right, in terms of communicating that there's a need. And pie charts are a nice, accessible way to show people, in different communities an extent of the issue. And then when you're at those community meetings, these are youth advisory board or youth advisory committees, family advisory committees, right? Having those people who are engaged and active in your program. If it's truly youth-centered and family-guided, then they're going to be providing direct input into how the program can address the issue. So generating a fact sheet, for example, on a specific topic like juvenile justice, this became a one-page handout that was then given out into different communities, and then they would inform the program staff in terms of how they need to make their services more welcoming to that population, provide better quality services to that population in need, right? Provide ancillary support services like tutoring and mentoring, right? So it helps to identify where the needs are, and it using data and using the direct feedback channels of the people who are most affected into how to best do it. So that's the quality that's being built here. So for example, this is an infusion site that we have worked with that we're serving ages 14 to 21, youth and young adults with SED who are transitioning from child mental health services to adult mental health services or from an institutional setting to the community. So when we developed their template or their model of their behavioral health disparities impact statement, we did the statewide, right? We cast the net large, right? We wanted the reports on teen pregnancy and unemployment and, whether if there was a report on treatment for youth or juvenile crime or, what's going on with this age range, this population of transition age youth with SED who are having all these life challenges, right? Dropout rates, et cetera. So these are all publicly available in reports and, things that were in different service systems, the different systems of care. And again, by gathering all the information, we're just trying to cull, it's kind of like, casting the net and pulling it all through and trying to line it up. But you have to make those data requests large, right? We want the report from the school system. We want the report from the juvenile justice system, or the court system, right? What data can we bring in the door to better inform our system of care? And so when we started looking at this data, for example, we started finding that there were different ethnicities that were being served in comparison to their representation in the local community. So there were 3 counties in this system of care, for example, with a Hispanic census population rate, not very small, it's 4.3% or over double digits at 10% and 13%. So people living in the community, an increasing emerging population. Yet when we looked at the services that were being provided to this population, we found that they were very, very small, like 2 people in one county, 1 person in another county, 5 people in one county. So what this helped to do is to then address, this is not like a gotcha, problem or, issue. You're internally using this as a tool to, to make improvements and to fine-tune the program and to address the needs in certain communities. And you're letting the data inform the direction, right? So by looking and comparing the number of people who were served versus their representation in the local community, it showed a need in the program, which is the right thing. It's always the right thing to expand the understanding around needs. So then it became, well, how do we address increasing our numbers of people who are served within this community? And they found that they needed to increase certain resources like an interpreter, right, or having things that were translated into Spanish, or having, volunteers helping out. So it helped to identify a gap or a need or an opportunity for improvement, and then there were action steps that were put in place or strategies for, for addressing that. So very positive steps for this system of care. And then when we look at the racial, the increasing numbers of specific populations, we want to make sure to say not all groups are homogenous, right? So not all Hispanic populations are the same. We know that people are from different countries, Mexico, Puerto Rico, or other countries, et cetera. So there, you can even look further, into your data to then look at the next level of how things are moving along for these populations. So then we looked at juvenile justice data, right, and then what is affecting the certain population groups. We looked at African American youth, right, in 2 counties, compared to all other youth combined. So to them compared to everybody else. And we found that they were more than twice as likely or more than twice involved in the juvenile justice system. So that's an instant disparity that jumps right out of the data at you like, wow, I didn't know it was that to that extent. I mean, you might know anecdotally or hear stories or, people talk about what the needs are in their community. But when you've got data like this, it shows the extent of the challenge or the extent of the need. And so this is another way to look at, comparing things across these data points. So SAMHSA wants everyone to have a population of focus table, right? So it's not just the one total number of people that are going to be served by the program. There is a definite component to breaking it down by race, ethnicity, gender, and sexual orientation or identity. And it's even by program year, like fiscal year 1, 2, 3, et cetera, right? And then how does it total up? And so this is a tool for the government project officer and for the evaluators in the program and for the administrators and the service staff to look at how are we doing, right? And so the estimate when you submit the grant application, and then as the program gets funded, it's the kind of how are we doing? And these numbers will adjust over time. These are targets that are here. But when I see this table sometimes when I go into different systems of care, what this has, and I've done a meta-analysis of different, all the ones that were submitted into SAMHSA and did a cross-tabulation of all this. In some communities, they would write things like not applicable or don't know or, no data or just zeros or something like that. Well, when I see responses like that, it concerns me, right? Because it's kind of like, oh, okay, so you're not even planning to serve any of these people throughout your entire program, right? So that's kind of like, it's a discussion point of, okay, well, is it that you didn't have the data, or is it that you just don't believe that these people, are going to be served? So there's a different way of looking at it, and this helps to, to move in that direction. So definitely there should be numbers of some kind, inside this table for everybody, right? So that's an underlying point. And there are other ways of looking at your cultural linguistic competence data in terms of disparities, disproportionalities. You can address the needs of attitudes, and changes in your community. So, for example, we used a scale, a 1 to 10 scale, about the acceptance of working with, racial ethnic populations, or the attitude of acceptance or rejection toward working with LGBT populations, right? And there's a way to put it onto a scale. And so we had wonderful trainings that were administered by Albertine Johnson Pickett here in Mississippi, where she did, hundreds and hundreds of different people who were trained, and they each received a survey at the end of the cultural linguistic competence training session, and it asked, before this training, where were you, right, in terms of your attitude toward working with this population? And then we asked, where are you now? Now that you've gone through this, hour training, couple-hour training, this training session, this learning community, where are you now? And what we saw wonderfully is this sea change of acceptance, right? And so this provides the data-driven rationale for why cultural linguistic competence is important, because it shows that change happens. There is a data wave, a wave of change, that happens from before to after. You can see the red data right on the left side, the little left red data on the mountain on the left, and then you've got the blue mountain on the right behind it. And you can literally see the shift from the red to the blue. So we were, the educational sessions were able to foster increased acceptance of working with. It's just wonderful, to see this, because we've got, the data and the evidence to show it. So that is one way that your cultural linguistic competence trainers and coordinators, can look at differences over time in terms of the impact of cultural linguistic competence. So in addition to the data, the numbers side of it, we also ask these open-ended questions. Like, could you please provide an example of how the information from the cultural linguistic competence learning sessions will be applied in your life, in your work? And there were wonderful responses that were qualitative and written in. And I think I'm very impressed whenever I see written in responses, because lots of times people got things to do or a next meeting to get to and busy lives and things, and at least they'll fill out the checkbox form. But when they actually sit and take the time to write down their thoughts, you know what I mean, to really provide a personal testimonial on what they felt or what they got out of like a nice thank you to the person who's providing the educational session, it's always wonderful to see this. So we saw things like it'll be beneficial to the clients that I serve, it'll help me be more efficient with the coordination of services, and just wonderful outcomes that came out from this. So behavioral organizational changes, and I'm just time checking right now. We're running till, I think, 3 p.m. this time. Yeah, okay, sorry. Just make sure I'm rolling with the time well. Got about another half hour. So organizational changes that are then based on using data and having this information available, the Behavioral Health Disparities Impact Statement describes how data will be used to manage the project and ensure continuous quality improvement, including consideration of access, use, and outcomes of disparities that are identified. So basically what I'm saying is you're trying to flip the data into data-driven strategies, right, to make improvements in service performance. And so how do you do this? Well, you have regular data reports, for example, to project officers and program staff that identify disparity data and areas for performance improvement. So, for example, I know that the Disparities Impact Statement, the first one is required, within a number of days between your, the notice of grant award and, when it's into your government project officer. But you want to make sure that's updated. It's not just the one. You don't want it to get cobwebs or dust on it, right? It should be a useful tool. So setting a timeline for updating it at least quarterly, right, or even biannually, at least to have some kind of update refresh to the numbers, because your community is changing and morphing and adapting to all these different things we're seeing in our society. So there's always different data reports that will come out, and so there's a need to refresh this information. So having regular data reports, and then having that direct assistance and discussion of data with stakeholders. Right, your community members, having that direct feedback loop, youth advisory councils, family advisory councils, like governance structures, et cetera, because you want to get their input, right, into what it means that there's a disparity like that in their community. And then to develop population-specific strategies on how to address those disparities in access, use, and outcomes. So how can we make services more welcoming? How can we improve the quality of services for these people? And how can we ensure that they have better outcomes? And then the final point on this is to develop a client-centered feedback loop to influence positive impacts in service delivery for those that are receiving services. So having a client-centered feedback loop is at the core of what's driving system of care activities and strategies, right? Client-centered. It always has to respond to that and always go back to that whenever there are different things that will come up in different communities. If it's always kept on the client, then we all understand, what it's all about in terms of why the program is doing what it's doing. So the number one thing for this is, if you haven't gathered, is to definitely have data in place. So the number one thing is to update your forms to collect race, ethnicity, and LGBT inclusive data, and this will help to improve practices, knowledge, and engagement. So lots of systems, they've got the intake form that their agency uses, for example, and sometimes I'll walk in, and I work in many, many different service settings and all across the United States, and someone will show me a copy of their intake form, and it's, the photocopy of the photocopy 100,000 times where you can barely read the, certain words and things. Because it's the template, it's in the file. It's been, used as pre-stuff charts and packets and things like that. So sometimes there's a paper form, right, or there's an electronic record system or some type of other intake system, but maybe the EHR or the electronic health record doesn't have inclusive race, ethnicity, LGBT data. during the demographic section. So that's the first thing, is to make sure that it is capturing it, in the system. So how do we do this? Because that's another question that comes up a lot, is to say, well, how do we ask these questions of these people? These are new questions. We've never done this before. Like what's the protocol, or what does it look like? Well, there are definitely guides, right? Official guides that are out there in terms of national surveys and how they've used this and posed this question. There's the National Health Interview Survey, or the NHIS, Measures for Sexual Orientation. And they ask the question, which of the following best represents how you think of yourself, right? And there are response options: gay or lesbian or gay, straight, that is not gay or lesbian or gay, bisexual, something else, or I don't know the answer, right? And it just provides that you ask it along with the other demographic questions, right? Hi, welcome to our services, and we'll be filling out some information today, and this is very standard, and it helps us to improve quality of services, and it helps us to understand the diversity of the clients that we serve. It's a positive, affirming approach to why you're asking questions like this, right? You're not just sort of like dropping personal questions on people, as soon as they walk in the door. You're introducing it, the purpose of why, what it can do, that it's going to help them, right? You're wanting to know more about the diversity of the people that are served. And so there are intake questions like by age, and their history, and lots of different intake types of questions. And so then along with those, we also ask people about their race. How do you identify your race? How do you identify your age? How do you identify your gender? So there's like it's a more inclusive way to understand diversity. So that's a question example. Then there's gender identity in U.S. surveillance, the GENI-USS group best practices for gender identity. And they ask, what sex were you assigned at birth on your original birth certificate as male or female? And then how do you describe your gender identity, right? So the current gender identity as male, female, male to female transgender, female to male transgender, or another gender where they can specify. So this will show you that you have people who are transgender within your program. So that's the way to do it. Those are considered the best practices, or the best questions at this time. And then another thing that can definitely help to look at behavioral health disparities is to conduct an anti-discrimination policy review. And this is to determine whether policies include race, ethnicity, and sexual orientation or gender identity. So for example, your employment policy in your agency, right, in the system of care agency or the fiscal agency, can staff who are allies feel safe to be out or provide support at work, right? So if somebody is in an agency and they're collecting the data on disparities, right, and this is, let's say it's considered a controversial topic or something that people don't think is a priority or whatever, right? For them to be able to ensure that they can do their job successfully, they may have definite support around having an employment policy that shows that this is something that the agency supports, right? So it's inclusive, that people cannot be fired from employment, for being either themselves who, of a different race, ethnicity, sexual orientation, or gender, or they may be an ally, right, to another a population of focus that's in need. So this helps to provide them with a layer of protection in order to get accurate data to implement the behavioral health disparities impact statement. And another thing is to look at partner agencies, right? In a system of care, when you're doing a lot of referrals to different types of service providers, let's say it's the housing provider, or it's the detox program down the road, or some referral type of arrangement. Let's say that somebody who is affirmed and welcomed and feels safe within your own four walls, when they walk through your front door, you've got a wonderful welcoming environment. But when you've sent that referral to them down the road, what's going to happen to them if they don't have an inclusive policy, right? So in a system of care, this is part of a discussion point during governance council meetings and youth advisory council meetings, family advisory council meetings, because the question gets raised, who's got an inclusive policy to protect this population? if there's a disparity among a certain population, what are the policies that are in place to help protect them in terms of providing inclusive services to them? And what we'll find is that a lot of service policies, like employment policies, they may have an anti-discrimination statement that you cannot be fired, by gender or by race. A lot of times sexual orientation and gender expression is not included, right? This is an increasing trend of inclusion that we're seeing spreading all across the United States, where these things are added and included into employment policies. And this also employs to vendor contracts, right? Subcontracts that your agency might issue out for services. It may be someone delivering the supplies, right, who comes into your agency. It might be somebody doing a specific professional service for you. Well, you want it to make it so that they understand that discrimination is not, is not tolerated within your own system of care, or that that people are really affirmed, right, for their diversity when they step through your front door. So it helps to structure this in terms of employment policy for frontline staff, partner agency policies in your system of care, and then those that are subcontracted with your agency. So you're covering all the bases of the levels of policy, for inclusion. And another strategy is to expand safe zones or safe spaces for all youth, right? And that is definitely a major intention and a major component of what systems of care are all about. They're for everyone, right? So it includes racial, ethnic, LGBT minority youth to have a safe zone, right? And so these are people who, there may be vulnerabilities and other challenges that they may be having in their life. You want people to feel affirmed and welcomed and supported, when they seek services. And so safe zone is one way to do this, and I'll provide some examples of signage and things like that. But you can basically designate a safe zone area in a structural way with a sign, that can be on the wall and have a statement of inclusion, or with symbols, things like that. So there's a way to designate that there's a safe zone of inclusion for people. And here are those wonderful examples. The systems of care, the rainbow logo is in the top left-hand corner, and that's reflective of the system of care logo. That's very inclusive of diverse communities. And then sometimes you'll see a pink triangle with a green OK type of symbol, or you'll see a multicolored example, or just a safe zone, things like that, hands coming together, or I'm an ally, right? There's different versions. There's no one exact example of how to put up a good, perfect sign around a safe zone. But even if you're not into colors or images and things like that, there can at least be a statement, like words. So for example, there's a statement on the top right here. It says, "This is a safe zone. This space respects all aspects of people, including race, ethnicity, gender expression, sexual orientation, socioeconomic background, age, religion, and ability." It's like, wow, that sounds like a pretty safe place to me, for a very welcoming, safe zone. And these are examples of safe zone signs. This is a picture that I took here in Mississippi, and this is actually in Corinth, Mississippi, where they had the safe zone sign as people were entering the building, right? And so there was one that's in Spanish next to it, and there's one that's in English. So this is a way you can, put this up and print it out, and have a symbol of inclusion. And this can be put, if it's not on your conference room door, maybe, or the front door, or the waiting room area, maybe it's people's offices. There's different ways to do this in terms of coverage. But the idea is to expand safe zones, that people are safer in more areas, and that they are expanding and making it so that people are more safe in more places. So this has been a very controversial issue that we've seen in certain states, where we are seeing a repeal of anti-discrimination policies at the state level, and this is all documented news things and trends that we've seen, where people are being sort of prohibited from using public facilities, and this affects the transgender population. And there are solvable ways for us to, live together in society. So there are ways to have all gender restrooms, or to have a family restroom, or have different symbols of who can use the restroom, right? So there's a solvable way that people can live together, and we haven't really seen crazy, events where, there's a lot of fear that we see around this issue that it just doesn't pan out when you look at reality and the data of, are there really incidents, that we are hearing about in terms of, transgender people going into certain bathrooms. So, and there, if anything, it's not non-transgender or not transgender people who are at risk. It's really transgender people, right, that are more so at risk for violence and other things. So the framing around the policy issues has gotten really mired. But again, the underlying point here is that we want everyone to have a safe place in terms of public facilities, in terms of where they are being served by systems of care. So some immediate and short-term things that you can do, and this is kind of a little bit of a laundry list, I know, and it's a lot of words on one slide, but and I'm going to leave some time at the end for some questions and follow-up. But these are opportunities, right, for you to, if you find that there is a disparity or disproportionality, here are some of the steps or ideas of things that you can pursue. And this can be monitored and updated within the Behavioral Health Disparities Impact Statement to kind of track how things are going, right, with these things. To identify training opportunities on selected topics, for example. It may be homelessness or suicide prevention or bullying, right, on a specific topic. You want to kind of narrow in to a specific issue because it'll make it more manageable to address it, right? Because you might find there's a laundry list of 30 different things, social-related challenges and needs. Okay, now that we've, gathered that all together, now how do we order it and, address one to the next in a linear fashion? So starting with a specific selected topic, to have a training opportunity like technical assistance support or training, from a university partner, or even to develop a training yourself on this issue in your community. To share learning content with service systems, right, programs, providers as widely as possible, and also other caregivers that are connected to systems of care. So foster care families, for example, or schools or faith-based organizations. Sometimes there are people who are supportive in a person's life they're not really thought about as something that, they can be better connected to improve, quality of life for people. And, or there's an assumption that they're not there or a resource. Like faith-based organizations, for example, are a great example of, major influence in people's lives. And sometimes there's a perspective of, they have different, different perspectives, and that maybe we aren't going to present the juvenile justice data to them or something like that. It's just there are assumptions that will creep in, and we want to make sure that assumptions are not, the step that's taken. It's an approach of inclusion, right? Always. So to also develop inclusive referrals for racial, ethnic, and LGBTQI2S youth and families, as I mentioned, within your broader system of care, to make sure that things are welcoming and supportive and affirming across the systems of care, across those referral channels going in and going out. To partner with community alliances, right? So people who are serving the different populations of racial or specializing in racial, ethnic, and LGBTQI2S populations, to identify inclusive success stories, right? And that is a continual theme. We want ongoing success stories from the systems of care of how they were able to address a disparity and they were able to make a concrete improvement in people's lives. I mean, that's the overall, something that we want to see continually expanding and growing. So identifying the success stories and sharing them widely is definitely a positive, wonderful step to undertake in the immediate and short-term stage. And then also to provide self-assessment tools, right, for staff to evaluate their level of comfort, acceptance, or stigma for working with certain diverse populations, right? So there may be a certain, thing that's discovered where, there's a perception of, not having a need or don't want to work with that community or, something like that. Something might creep in. So let's make it objective about, it's not about you, it's about the clients, right? It's about their needs. So a perceptual barrier that's personal, right, that is a way to overcome that, right? Make it about the clients and their needs, and it's not about the person's, bias or challenge. So there are some tools to identify, where are they at, in terms of their acceptance or rejection. You can also conduct asset mapping by identifying and connecting with local, state, and national resources. And asset mapping is a way to extend the reach of systems of care, right? These are things like gaining letters of support or memoranda of understanding to support your grant applications, conducting diversity or climate surveys, and also identifying safe space resource champions who can provide resources and share information further within your community. To develop train-the-trainer resources, connecting with other systems of care, and then also conducting social marketing activities. So these are all doable things, right, within not 6 months, right? These are throughout the program, right? These are all major positive things that can be conducted to improve and to address disparities and make improved equality. So thank you so much for your time, and I will return it to Kathy to facilitate our questions. Thank you.
Great. Thank you, Peter. That was very, very helpful. And, again, as we said when we opened this up for questions, any questions or comments, is that we really want to make these behavioral health disparity impact statements, a useful tool for you, and not just another SAMHSA requirement or something that you have to write now, but how to make it a useful tool for you, and how to integrate, your efforts at achieving health equity and addressing disparities and disproportionalities, and integrating it into your larger strategic plans. So go ahead and open it up for any questions or comments.
Oh, Kathy, I have a question in terms of self-assessment tools and where to find them. And I will definitely forward a resource. We have a webinar on self-assessment tools. Is that right, Kathy, in terms of a specific resource that's available on the CLC Hub? Mm-hmm.
Right. We have that. We also have a, and I think I saw Linda and a couple people from the CLC Hub on the call, a library of resources where there are actually examples of some of the disparity impact statements that some of the communities have written in the past. And so those are also available on the CLC library, resource library.
Yeah, and any individual questions as well in terms of, specific, templates and, ways, that people can, if they're pursuing a certain specific topic of a disparity and want some guidance, I'm available in terms of follow-up as well for any individual requests.
Yeah, Emily wrote, will our project officers be able to assist us and answer questions as we develop our impact statements? And I would say yes, they are available, I'm sure, or they may also refer you to the Cultural Linguistic Competency Hub, and specifically to Peter or to myself. But Peter is actually available as part of the TA network to provide that kind of support also. Thank you, Linda.
Yeah.
For
thank you, Linda. Yeah, I was just going to say, I just saw the link come up.
Great.
So if you click on that link, it'll bring you right to the CLC Hub website.
Any other questions?
Nope.
Nope. As I said, there are a number of, and there are actually some examples of behavioral health disparity impact statements that are not posted in the resource library that are more recent, that we may be able to also, we always try to ask for permission from the sites before we share anything, but we have some of those available also. So if you're looking for examples, you can go to the CLC resource library for those examples, or you can ask us specifically, and you can email Peter or myself specifically, and we can get you some more examples also.
Yeah, we've collected now, since fall 2013, we've collected some great model examples and just wonderful resources, to look at and review, how other communities have successfully done that well.
Right. And you may be hearing from us in the near future too, in terms of, I know that you have to submit the statement to your project officer, but we may be asking if you would be willing to share it with us also, because Peter had mentioned earlier that we did a meta-analysis, I think of about 18 of them from previous sites, from previous grantees in previous years, but what we would like to do is really begin to collect them, to continue to do this analysis of what the needs are when people are creating them, and then a follow-up on, how it was used and was it helpful? And so, because I think that's the kind of thing that can be really useful for other grantees too as we move along.
Yeah, and that helps to find this, to probe to see about success stories as well, which is that next loop, that we really want to zoom in on, and how this was able to improve quality and help people, through the use of this tool. And we're up to, the first pass, I think, the first year was about, you're right, Kathy, it was about 18, and now we're at way over 30. So we've got a nice cluster, a sample, all across the United States of different approaches, and different strategies of how they were saying they were going to address certain disparities and disproportionalities.
Thank you. Well, thank you all very much. I'm not going to keep you on any longer. Wait, Emily is typing something, and we're very happy that this was helpful. And Peter, excellent examples again that really help in terms of, Deborah said, very detailed and helpful. So we're happy. And as I said, Peter is available, as is everyone from the Cultural Linguistic Competency Hub, to continue helping you, make these behavioral health disparities impact statements. Again, something useful, something that you can really help and measure how well you're doing. Okay, so if there's no other questions, I'm going to go ahead and give you guys back 5 minutes to your day, and thank you all. Oh, Michelle? Thank you all very much for your attendance today, and we'll be talking to all of you. Thank